now listening to Extracting Wisdom. Here to help you prevent the decay of your future is your host, Brandon Evert.
Hello, and thank you for tuning in to another episode of Extracting Wisdom. I'm your host, Brandon Evert, and we are live at Day 2, Voices of Dentistry. And joining me on this episode, we have Dr. Brian McGue. Thanks so much for being on the podcast today.
Oh, great, and thanks for having me. Really enjoy it.
Of course. That's kind of funny. Your son actually goes to the same dental school with me.
Yes. Yeah.
And your younger son went to undergrad with me, so it's kind of cool that we have that connection.
Yeah, very cool.
So you are a part of the 3D dentist kind of curriculum or ring or circle.
Yeah, the posse, the gang,
the posse.
Whatever you want to call it. Yeah, the 3D dentist faculty.
Right.
I don't know.
And you kind of are the expert on sedation with the 3D dentist.
Yeah, so I teach their a minimal oral conscious sedation class for adults.
Okay.
Yeah.
And I thought it'd be great to have you on the podcast today because as dental students, we don't get a whole lot of exposure to sedation, really.
Right.
So I would like to just kind of learn a little bit about, I guess, an intro to sedation. So what do you typically do in your practice? Is it conscious sedation, or are you putting patients all the way under, or what do you typically do in your practice?
Yeah, so typically it's oral conscious sedation. So
Okay.
It is a conscious sedation, and sedation is organized into 4 levels. You know, you got your minimal, moderate, deep, and general.
Okay.
And really what we're looking at is obviously we're never doing general unless you're going into an OR and an anesthesiologist is doing that.
Got it.
A deep sedation is not really your target, but if you're doing like IV sedation, that kind of stuff, some of your patients are going to slide into deep sedation. That's why you have to be ready to reverse them if you need to.
Right.
And then going up the scale, moderate, that is a typical kind of IV sedation you do with like a third molar removal.
Okay.
And then minimal is minimal oral conscious sedation. It's an oral sedation, and that's really our target in this course is minimal oral conscious sedation. Now, will minimal oral conscious sedation patients slide into moderate? Yes, absolutely, but it's not a problem usually. You know, it just means they're a little more asleep than that. You know, they're not as conscious maybe.
Right.
But that's not a problem. You're monitoring them. You're watching their pulse oximeter and all that.
Mm-hmm.
So that's our target, is to do that. And you will find with minimal oral conscious sedation, which I'll go through the process of how you do that.
Sure.
But you will find that does a lot. I mean, I do everything from full mouth extractions and putting in 16 implant kind of thing, you know,
Right.
that kind of I do it I've done a lot of them under oral conscious sedation. We have patients that we have to do oral conscious sedation for provies. And that is the thing that I try to impress upon people is that sedation should be one of those tools that is sitting on your shelf to make you be able to do a better job at what you're trying to do.
Right.
And as a dental student, you've probably already started to see this or experience it, is that sometimes people are hard to work on.
Yeah.
And their anxiety or just not wanting to sit there or whatever can really sometimes influence what you're trying to do. And when you get into private practice, you know, there'll be some cases that, man, you just get in, you get out, you know, as fast as you possibly can.
Right.
And the quality may not be what you're up to, you know, your standards. And you don't really feel that good about that. You know, you walk away from a case like that, and you're like, darn it, I could have done a better job, you know. I equate to sedation as like, it's like you're putting on a rubber dam or you're putting on an ice slide in the patient's mouth.
Right.
What you're doing is you're trying to take some of those factors that may influence what you're trying to do, whether it's pushing the lip and the tongue out of the way with the ice light,
Right.
or you're taking the patient's anxiety out of the equation. So now you can sit there and work on a dentiform, which is the best way to do dentistry.
Exactly. Yeah.
So, my goal, kind of as I started teaching several years ago, was I really saw a need of general dentists that just were not using sedation. Part of that, there was a lot of disinformation about, you know, oral conscious sedation out there, that it wasn't safe and all this kind of stuff, and we'll talk about that. But I kind of my mission is that I want to get, you know, general dentists to say, have this sitting on their shelf. And it's not every patient, but, you know, and there are patients that need it. And like I said, it's definitely not procedure driven. There are some procedures you probably want to, like doing implants. or taking wisdom teeth out or something like that. But there's also a lot of patients out there. There's about 30% of the population that won't even walk into your office because they have a debilitating fear of dentistry.
Right.
Yeah, and so it's in that respect, it can also be a practice builder, because some of those people are not going to walk into your office because you're going to sedate them.
Right.
Yeah, and it could be for a prophy, or it could be for the occlusal on number 3.
Right.
Or it could be the extraction of 4 impacted wisdom teeth.
So with that, I would like to know your process with the patients. Like, is that something you typically will tell them, hey, we're offering this if you want it, or will you typically kind of feel out the patient to see if they're nervous or anxious, and then you will offer it to them?
Right. So usually the patient assessment, and we do this in the course. We teach you how to psychologically assess them, just kind of looking at them. It starts like at the comprehensive exam.
Sure.
When you got them in there, first meeting them, and you're just watching their body language. Are they sweating? Are they looking you in the eye? Are they, clenching their hands on the chair?
Right.
That kind of stuff. And you'll start to pick up on it. And then a lot of times when I'm starting to, when I start talking about some of the, like, oh, maybe we got to do quadrant restorative or something. And I'll say, hey, there's different ways to make you comfortable for this. Let's, there's a sedation we can give you. It's an oral sedation, and you just come in here, you take some pills, come in here, someone drives you here and back. And, if you have concerns, that's a good way to go. And some people will jump right on it. Somebody like, hey, I want that.
Yeah.
And then other people say, I'm fine. Just, I've had dental work before, I'm okay with the local anesthetic.
Right.
So, and it just varies from person to person. I try not to be judgmental with patients.
Yeah.
If they need to be sedated for prophy, I'm okay with that. I don't have a problem with it.
Right.
It's, all I want to do is make sure they're comfortable.
Right.
So that's the assessment, when they start to look at it. And my staff's pretty good at it. They'll come this one needs to be sedated.
Right.
And you'll learn that pretty quickly. I mean, patients will put on a face for you and an air for, and then you walk out of the room and they'll be like, can I be sedated? They don't want to admit to the doctor that they're scared, and but they'll admit to the assistant, or the hygienist, or the front desk, or something, So they're probably better at it than I am.
Gotcha. Yeah. So, take me through the process of oral conscious sedation.
Sure. Yeah. So let's go through. So let's say I identify a patient that I want to do an oral conscious sedation on. So we have them in first for, it depends on the procedure, usually the night before, like the day before the procedure, or it might be a week out from the procedure.
Okay.
The ones a week out is if I'm going to be making a surgical guide in my office, I'll have them a week out, so it just gives me a little extra time to do the surgical guide if I'm doing an implant. So they'll come into the office, and we'll do a medical history rundown with them. We'll go. Usually the assistant, it's assistant driven. They'll do most of the assistant. We'll talk them through what this is on it, what kind of medications are you taking. And then usually very quickly the assistant comes back to my office and hands me their medications. And then I sit there and I'll run it through Lexicomp. And Lexicomp's a great online service, and they do a nice job. They support the course pretty well. They let us get on all the students without a fee or anything like that. Anyway, and I'll run it through, and that's a wonderful thing. It gives you interactions of what's going to interact with the sedation drugs you're going to give them. And so sometimes you have to modify. You might look at the lexicon and say, okay, maybe they're taking Ambien at night for sleeping. So maybe we either have them stop the Ambien, or they can take the Ambien, but then we're not going to give them an anti-anxiety dose the night before. So. And then I go in and I do a upper-lower respiratory exam on them, which is just checking to see if there's any wheezing, either the stethoscope. While when they first walked in the operatory and sat down, before they started the medical history, one of the assistants have hooked them up to the monitors that we're going to use. And generally you're going to want a pulse oximeter, something that does heart rate, something that does blood pressure. That's the big three. There's some other ones, and there's like SBO2, CO2. Yeah. I mean, not SBO, but CO2, end-tidal CO2. There's, I won't go into that thing. It's not that valuable.
Okay.
So yeah, and a lot of states don't require it or anything. Actually, no one really requires it. So, monitor, you want to do O2, heart rate, blood pressure. And so you're getting a baseline. We're using the same monitor we're going to use during sedation, because monitors do have differences in them. So. Anyway, so they do that. They're sitting there. They've gone through medical history. I've gone through the Lexicomp. I come in. I do an exam. I'm looking at the procedure I'm going to do. I'm looking at their upper and lower respiratory. I'm listening to their chest with the stethoscope, waiting for breathing. I kind of go over their medical history again. I talk to them about the medications. And then from there, after I've done that assessment, then I say, okay, well, I'm going to go back and we're going to get the medications. I'll go back to my office and I'll dispense them out. And usually what we're doing is a standard, kind of the standard sedation protocol, is that we're going to give them an anti-anxiety medication the night before. And it's usually diazepam Valium. And it's really to just get them to sleep well and take some anxiety out, because there is some good research that shows that if you can drop their anxiety at home, when they show up, it's going to be easier to sedate them. So that's one of the reasons you do that. And then I give them a little, pill thing with that, and then I give them a pill thing with the medication that's going to do the sedation the next day. So that an hour before, they're going to take the sedation at home, medications, and they have to follow the protocols of not eating or drinking and all that kind of stuff.
Okay, yeah.
And then they're going to, someone's going to drive them in. Once they hit the door, an hour later, they're starting to feel a little bit sedated at that point on an empty stomach. We're going to bring them right back to the operatory. We're going to hook them up to the monitors. At that point, they're never going to be left alone. Somebody's going to be with them. It's almost always going to be an assistant. I'm going to come in there. I'm going to usually place local anesthetic. If it's an implant case, I might go get dressed in my big, surgical gown and all that kind of stuff. If it's a restorative procedure, I might go check a hygiene or something like that, and then I'll come back. The patient's isolated, ready to go. We do the procedure, and then afterward, they usually, and they're monitored the whole time, and then afterward, we start to kind of stimulate them, wake them up if they're falling asleep, put them in a wheelchair, take them out to the car, put them in the car, belt them in, and then someone else drives them home. So,
got it.
Yeah, so that's it in a nutshell, kind of quick and dirty pass through it.
Well, no,
yeah.
I like that a lot. That's, we don't, in dental school, get a ton of exposure to that, so it's good to start thinking about that is a treatment option that we can provide to our patients down the road.
And if you do, if you learn how to do it correctly, and the patient assessment, there's 3 ways you get into problems with sedation, okay? And this is from a 1983 study, and so it's still working. So it's your poor patient selection. You're sedating somebody that really shouldn't be sedated. This is an ASA classification 3 or 4 person. You don't touch those people. You want to do 1 or 2. You dosed them wrong, like based on their medical history, their age and stuff like that, you gave them the wrong dosing, and then the third thing is that you didn't monitor them correctly. You did not have those monitors on there. You didn't have somebody watching the monitors, and if you didn't do that, then if they started to crash on you, you weren't aware of it. So that's the 3 things, and like I said, that study is from 1983. It still stands today. If you look at the cases where someone did something wrong, something went wrong in sedation, most of them are going to be one of those problems. It's a bad selection, bad dosing, or bad monitoring.
Gotcha. Okay, so a couple questions. One, how, after you take their baseline blood pressure, what is, the expected blood pressure drop? Is there is it supposed to drop, and, when is it considered dangerous?
Sure.
Of how much it drops?
Yeah, so blood pressure is kind of an interesting thing, because it's really a measure of chronic problems than it is an acute problem. What we'll see when we sedate a patient is usually about a 20-point drop in their blood pressure. So when they're sedated, just because they're sedated, they're more relaxed in their blood pressure, and they're laying back, a little bit, and their blood pressure goes down. And which is one of the reasons that hypertension is actually a good thing to sedate, because you're going to keep their blood pressure low, and that's good. So, and if you notice in a sedation scenario, what's most likely going to happen with the blood pressure is you will start to see, if you're doing a long procedure, the systolic blood pressure may rise. And what happens there is the patient is probably starting to feel it. Their local anesthetic is starting to roll. So if I look over and that systolic starting to rise up again, I just reach over, pick up the anesthetic, and just give them a little more. And that's usually it. So, like I said, blood pressure is not really as an acute problem. The thing you're really watching is your O2. Yeah, that's the biggest thing. So, if this starts to drop to 90 or below, then what we'll do with the patient is a lot of times they're sedated enough, they're not breathing as deeply. So you maybe, reach over, kind of reposition the jaw a little bit, and you just say, "Hey, Bob, take a breath." And they'll go, and then all of a sudden, it's the coolest thing to watch. All of a sudden, the O2 goes right back up. You go, okay, or let's take 3 or 4 breaths,
Right.
And that's pretty much most of the time that you'll see kind of a true sedation. And then If they stay there and they're doing fine, but most of the time it's just that they're sedated, they're slumping a little bit in the chair, their chin goes down, their airway closes, and you just got to open it up and take a breath. And I talk about this a lot, but I've been doing sedation for a long time, decades now, and I kept a log of my sedation cases.
Really?
Yeah, and and it's a lot easier to do now that we have computers.
Right.
But I've kept a log, and I've done over 11,000 oral conscious sedations, and I have never had the need to reverse a sedation. So, and it's not that I am an outlier. It's not that I'm really lucky. It's just that's how safe oral conscious sedation can be done if you do it right. If you assess that patient well, if you dose that patient, you're going to be well. And I'm not going to say that you're never, no one's ever going to have a problem. There's going to be some complications somewhere. It's just I haven't had a real serious one that I've had to say, okay, I'm going to reverse this sedation, and we're going to get the patient out. We're going to end the procedure. I just never had to do it. So,
knock on wood.
knock on a lot of wood. Yeah. But probably Monday I'm going to have a problem. So so.
Well, that's good. Another thing too. It just happened last summer, last fall? I sat next to you at Implant Pathway.
Yes.
That's when I first met you, and I walked in, and it was hilarious because I was like, you look a lot like Tom McGue, But I remember you were talking about you were starting to do some research into the correlation between conscious sedation and marijuana.
Oh, yeah.
And so that's what we're starting actually to learn a little bit about at school in our small group learning and everything because it just got legalized. So is there any research about that yet, and how strong is it? And
yeah, so I gave a lecture at the AGD annual convention last summer on that, and it was great because I got a lot of feedback and a lot of questions. It was awesome, in that respect. You always, as a speaker, you love to hear people, raise their hand and ask questions. Okay, so here's the problem with marijuana is obviously it was a legal drug, and there's just not a lot of good research on it because of it's a legal drug, because it's hard to get the funding, get the permits to do the research. So a lot of pharmaceutical companies aren't going to do a lot of research on something they're going to not make money on, and then they have to go through a lot more hoops to do it. So a lot of the quote research or findings on marijuana is anecdotal, and it's not well researched. So, but here's some interesting things about marijuana is that marijuana is fat soluble. THC, as we should say, not just marijuana. THC is fat soluble, and so it hangs around in your fat, after you smoke it or eat it or whatever you're going to do with it. And when you have a fat-soluble drug, is that it doesn't clear the body very well, so it actually will store in the body. And if you have somebody who's a chronic marijuana smoker or eater or whatever, they have built-up reserves of THC in their tissues. And they can be walking down the road, 3 days after and all of a sudden they'll get high.
Boom.
Yeah,
just like
it
that.
just comes in. Yeah, wow. It's like the gift that keeps on giving.
Right.
And it, which is funny, but I think we all have an experience when we go back to high school. We know people that use marijuana a lot, and they kind of look like they're kind of baked out the whole time, and that's probably what you're seeing is that there is some that's floating around. But from a sedation standpoint, that is. THC is a CNS depressant, and one of the big things you concern yourself when you're doing sedation is you want to see how many CNS depressants are on board this patient, because you want to overload them and then you're going to, have a problem. So, because it's going to interact with the sedation drug. So for THC or marijuana, you have to really delve into with the patient, how often have you used this? When have you been using it? I find that it's easier to talk to patients now about it, now that it's legalized in some states, and it used to be such a taboo subject. Some of them will be up front and talking about it. Others may not. I mean, you're still probably not getting the full thing. A lot of times I'll ask them is, first time you ever started using it? What year did you first start using it? Instead of asking them how long have you been doing it, or how often, or I'll ask them, when's the last time you used it, and that gives me a better idea. But if there's someone who's used it chronically, you have to really be on top of that. Yeah, but the subject's fascinating. I mean, I've since I gave that lecture 6 months ago, a lot of things have come out, and it's just I'm constantly reading up and rechanging that lecture, because I give that lecture in the course too, because there's a lot of interest in it. And the way I kind of got interested in it is a couple of years ago I was doing this course, and I had a Canadian dentist, and they were just about to legalize. And she came up and asked me that, and I was like, I'm going to have to come back to you on that one.
Right,
Because I wasn't totally sure. I mean, I knew it was a CNS depressant, but, stuff about the fat soluble part of THC and that they could, just be walking down the road 3 days later and spontaneously get high. I didn't know that, So it was kind of interesting to go back in the literature and read about it.
Yeah, very interesting. So here's another thing. We're going to switch gears a little bit from sedation.
Sure.
I want to pick your brain about what do you think dentists or dental students now coming out of dental school, what are some good things that they should do to prepare themselves for success in practice?
Okay. All right. So let's talk clinical first.
Okay.
Okay. So, clinical, there are so many things in dentistry to learn, and I'm, 54 years old. I've been doing this for a long time, and I'm still learning. It's still amazing how much is still out there that I haven't learned. And I'm a kind of a CE geek, I'm like, got my fellowship in the AGD and all that. But I still don't know. So the thing is I think as someone's coming out of school, and like I said, my son's a fourth-year dental student, I've started to have conversations with him about this, is that, first start with kind of restorative dentistry. Get good at doing endo. And there's so many, and you were taught one way of doing endo in dental school. And when I don't badmouth dental schools, they have to teach you one way because they can't teach you 5 ways. They got to teach you one way to do it and then get you through. And when you get out, then start looking at the other way. But there's some really well done ways of doing endo, very efficient ways of doing endo. So let's do that, and then along the way, just take some courses on just doing direct restorative stuff and crown and bridge stuff, because that's going to take you far. That's going to give you a baseline. That's going to, if you're looking at from an income standpoint, that's a lot. I just ran the numbers on my practice last year, and you look at all the things, and my restorative is like 60% of my my production is my restorative, so that's going to give you a good baseline. You're going to be able to pay the bills. You're going to make a good living off that. Start looking at implant dentistry early.
Yes.
Okay.
I completely agree with that.
Yeah. So and you were at Implant Pathways, which was outstanding because implant dentistry allows you to look at things in a different manner. When I came out of dental school, implants were a really new thing, and not a lot of people were recommending. It was almost like you looked at implant dentistry as the last possible thing you could do.
Right.
It was like, let's see if we can put a bridge there. Let's see if we can do a removable appliance. Okay, we can't. Let's do an implant. And now it's totally flipped over where it's like, hey, the ideal treatment is really to put an implant in here if we got the bone. And then, maybe we'll do a bridge if you don't want to do that, or a removable appliance, So start with implant dentistry early on. And that again, I'll plug in Justin's course. The Implant Pathways is an outstanding course. There's other ones out there, but I thought Implant Pathways was very well done. Because you want to get comfortable placing onesies and twosies.
Right.
Don't try to jump into full arch stuff. I did not do really full arch stuff till I had been doing it for many years. And it's because it's dentistry learning is repetition. Whether it's doing an amalgam or it's doing a crown prep or it's repetition. And that's a beautiful thing. But it's same thing with implant dentistry. You just get comfortable dropping ones in, fully guided, and then you'll find out sometimes that you got to go away from the guide. Sometimes, I love guided implants, but sometimes they're not 100% perfect. Like you do that hole and you start looking at it and you're like, that's not where I want this thing to be. Yeah, and you got to freehand it there. So you got to get comfortable doing both ways. And then once you're done, you've got a bunch of these underneath your belt. Yeah, and then let's all right, let's take out all these teeth and put some immediate implants. And start talking that stuff. But
yeah.
Don't rush into that. There's a lot to learn. You got a long career to look at. So that's the other thing. Along the way, there's other things. Oral surgery. I love oral surgery, and I think just getting comfortable taking teeth out, bone grafting, putting socket preservation grafts. That's and it's not that hard. I mean, it's just, you just got to get comfortable doing it.
And that sets you up for success down the road if you're going to place an implant. Even if you don't, though, I mean, you preserve the ridge there.
Yeah, and so I think that's it. And then, on the soft skill side of things, practice management stuff. It's going to depend on what you're doing. I mean, are you going to go into a PPO kind of practice? Are you going to go into a managed care? Are you going to go into fee for service? And you then figure out what you need to learn on doing business. And I enjoy talking about the business side of thing, but I'm also one of those people that thinks that it's not that complicated. It's kind of common sense.
It is.
Yeah, but
I was just gonna say, I think you can make it as complicated as you want, but at its core, like I agree with you.
It's money in, money out.
Right.
I mean, it's like, how much money you're going to spend to do this, and then how much money, are you want to be able to make a living, and when you have a family and all that kind of stuff.
Yeah.
But it's, if you get good at, and there's so much out there that you can just find something that works for you. I was. When I came out of dental school in 1992, I had zero money. I started a practice, and I didn't have money to really hire somebody to help me manage a practice. I'd love to have done it, but I just didn't have the money. It was pure and simple. So, I mean, Howard Fran. Yeah. Now, didn't you interview Howard?
Well, here's the thing. I just had him on yesterday, but he accidentally kicked the power cord. So that and everything shut off mid-episode. So I think I'm going to track him down here on our second day and see if we can redo that episode.
So anyway, I mean, I'm just using Howard as an example. Is that he was like one of the only people at that time that was talking the business side of dentistry.
Okay.
And he had like a cassette program. It was cassette tapes. That gives you the
really?
I'm dating myself here, but he had, it was called the 30-day MBA. And I just got those, listened to him, and it was just, he had a very down-to-earth way of talking about business, and I incorporated a lot of those business principles into my office. It took off. It was successful. It's still successful, 25 years later. But what I'm using as that example is that, there's a lot of information out there. Now we have the internet, we have Facebook, there's so many, it's out there. You just got to pick some route, someone that you trust, and go with them, along those, so that's kind of getting going. I mean, there's stuff, you talk about like technology. I'm a CEREC doctor. I love doing CAD/CAM kind of dentistry, and you have to look at your bottom line on that. I mean, some of that stuff's expensive. Yeah, but if you got to look at it from, okay, if I'm paying this much to a lab, if I can pay this much to own this billing device, and I can do it myself, it's eventually very quickly the ROI is going to take off.
Right.
So that's stuff you got to look at.
Yeah, that's something too I'm thinking about, is like when it comes time to open up my own practice, like I'm going to try to get a lot of that technology like right off the bat, so I have all of that time to put it to use and to pay it off.
Yeah, and it impresses patients.
Oh,
yeah. I mean, when they're looking at cone beam, you're showing them there's three-dimensional view of their sinuses and where you want to put that implant, or they're looking at the crown milling out. They're like, they think this is the coolest thing. Yeah. So.
And I was just talking to a couple other dental students the other day. I saw Sully. I think it was a couple months ago. He had a little story on Instagram of him in his office throwing out all of his stone and all of his alginate and everything, because he's like, I'm done with this. He's like, I'm all digital at this point.
Yeah.
Which I think within the next couple of years, I think that's going to be like the standard of care, is all digital.
Yeah. I don't know if it'll get standard of care, just because there's a big portion of the profession that still is dragging their feet on it. I'm a big, I mean, it's funny. I would love to go totally digital like that, but it's still like, sometimes it's still a little bit more. It's still, sometimes it's a little bit laborious to scan somebody and then print out a model, where an assistant can just go take an alginate in 3 minutes
and pour it up
in 3 minutes, and then it's there.
Right, exactly.
Yeah. And it's just, I'm still looking at it that way, but I would love to just go totally digital. And it's just that right now I'm looking at it from a cost factor, and I'm like, it's not there yet. But hopefully, I don't have a 3D printer in my office right now, so yeah.
Gotcha. Well, thank you so much for being on the show. You shared a lot of awesome advice on sedation and what I need to be looking out for as I end my dental school career. So I really appreciate that. And thanks again for being on the show.
Yeah, well, I've enjoyed interacting with you. Like I said, I
Thank
didn't
you.
plan pathways,
Yeah,
and now it's
absolutely.
fun. I'm just enjoying watching you go through school. And
Thank you. I appreciate that. It's been a great time getting to know you, and I'm sure we're going to run into each other again at different meetings.
Yeah, we'll see each other lots.
Absolutely. All right, take care. Thank you so much.
Take care, Brendan.